GECO session. As you know, the GECO meetings are held weekly with various topics on each week. GECO is hosted by the Gessler Foundation in association with Project ECHO from the University of New Mexico. And the chat will be open for any questions. As always, we do encourage interaction and discussion, so please feel free to post any questions in the chat. This week, we're going to be doing a pathology session, but it's more a mixed session with pathology combined with endoscopy. We have Prof Hale from pathology, and I think Prof Hale needs no introduction. He's well known to this platform, and he's really one of the very few expert GI pathologists that we have in the country. So it's always a pleasure to have his input. And the idea for these talks really came about, we often rely heavily on histopathology to make a diagnosis. But what we forget is that the histopathologist equally relies on us to come to that diagnosis. So working together with your pathologist is fundamental in helping your patient. We both provide pieces to the puzzle, and together we have a clearer picture of what to do. And as endoscopists, we often look at the lesion thinking, what is that? Is that something? Should I take it out? Should I leave it in? Let's just take a biopsy and see what it is. And the key is actually to be aware consciously of what you're looking at. And I always tell my fellows, don't just take a biopsy. Chat to your pathologist and follow up the biopsy. Because if you don't actually follow up the result and another doctor sees the patient in clinic, it's an absolute wasted learning opportunity. So I remember Prof Hale telling me that pathology is an art form. And I think it's very true. If you look at any sort of art, whether it's abstract art, the key is your interpretation of it or what you think of it. And I think the same holds true for endoscopy. I think it's an art form, and there's two components to it. The first component is taking a beautiful picture. The second component, which is equally as important, is interpreting that picture. So we decided that this is a good idea to collaborate on the endoscopic image and the pathological image. And we're hoping to have a number of sessions. Today, we're going to keep it to the upper GI, more specifically to Barrett's esophagus with adenocarcinoma. But hopefully, we'll have a series of talks where we look at stomach pathology, we look at duodenal pathology, colonic pathology, and really just come together as a unit in terms of pathology and endoscopy. So I'm going to just start by sharing my slides, and I'm just going to show you very few slides on some tips that we can use to image Barrett's. And I'm then going to show you a case study and a video presentation, and then hand over to Prof Hale to take it from there. Now, Barrett's is very difficult. The stomach and the esophagus are probably the hardest areas to image. And they do need lots of subtleties, and you do need to know how to interpret what you're looking at. And it can be very difficult. And while we're trying to teach people how to interpret it, just also to be aware that ideally these difficult cases should ideally be managed in high volume centers. And if it's not something you're looking at often, it can be very difficult to interpret. And the crux is you got to get it right the first time, because if you don't get it right the first time and you go with the wrong therapy, you often lose that opportunity to cure your patient. So if you do an endoscopic resection and you don't get a good margin on the lesion because you misassessed it, you then get fibrosis and you've lost the opportunity to actually cure your patient endoscopically. So getting it right the first time is quite important. So just two slides quickly that just gives you some tips and tricks that I use when I'm imaging patients with Barrett's. Just a few points. So the first thing is sedation. It's absolutely important to have your patient adequately sedated, especially if you know that they've got pathology and you need to spend some time looking at it. Having a patient gagging and vomiting and pulling out your scope absolutely hampers your ability to image these patients. So together with sedation, these procedures need to be timed. You need to spend or you need to allocate enough time on your endoscopy list to actually assess the lesion. Now, just to bring you back to guidelines, just remember that all the guidelines, whether Europeans or Americans, they're all advocating spending a minimum of 1 minute per Barrett centimeter segment. That's probably not even enough if you look doing adjunctive imaging techniques like using acetic acid chromoendoscopy. So 1 minimum is actually the bare minimum. Then there's other things that can help you when imaging these patients. And one of the things that I am quite a fan of using and do use often, and you'll actually see it in my pictures there, is the use of a distal attachment or a distal transparent cap. So it's a little cap that goes on the tip of the scope. And where the value of that comes in is often you try to get up close to a lesion. And when that lesion comes against your imaging, your scope, your screen, you get red out. So the cap just gives you that little bit of distance to keep the image off your monitor and to actually get you a nice image. You can also set the cap on a lesion, isolate it, and put that lesion under water by just filling your cap up with water. And water really does help to magnify images and give you much clearer pictures. The other thing to mention is that it's fundamental to clean the area adequately. You often miss lesions due to mucus, due to bubbles. So remember irrigation, whether you're using a water jet or whether you're just using syringe irrigation. If you are using a water jet, I'll mention this a bit later as well. Be careful of the pressure of the water jet because you can traumatize lesions and cause them to bleed, and that just makes imaging more difficult. The use of mucolytics like N-acetylcysteine for mucus and simethicone for bubbles. Then the other thing I see a lot of endoscopists do is try to capture a moving image. It just doesn't work and it's just so difficult to do. Whether you're taking pictures or you're just assessing something, I urge you to use your freeze button on your scope. Know where your freeze button is, program it to an area that's convenient for you to access on your wheel and freeze the image. It's very difficult to interpret a moving image, but when you freeze, you can spend time and actually sit back and just appreciate what you're looking at. Remember the prior classification when we were dealing with parrots? So I think that most people will be familiar with regards to circumferential and maximal distances, and as well when you have hiatus hernias, because that can become a little bit tricky. So what you want to do when you're looking at the parrot segment is first you want to just step back. So what I mean by step back is, just get off the lesion, as you can see in this last picture, and freeze your image. Just step back and look for things that stand out to you. So with the Geeks Foundation, we like to refer to this as your first impression or your blink impression. And with parrots, there's really a few features that you're looking for. The one is extra redness. So you see an area where there's extra redness, like in that second picture. If you see areas of spontaneous bleeding or contact bleeding that are very friable, that's always a concern for a dysplastic or malignant area. Of course, ulcerated areas are always of concern. But one of the key features with regards particularly to parrots that is a harbinger of dysplasia or malignancy is bulkiness or nodules. So after you take a step back and look, that's when you want to then take a closer look. So now this is when you use your imaging modalities. And I would like to, or I try to convince you that you don't need the highest generation, top-end high-tech scope with 4K definition to image these patients. Rather, be familiar with what you have. So most of the images I show you today are all taken with a standard Xera 3 HQ190 scope or H190 scope. So those are probably one of the most common scopes that we all have. So you don't need high-end imaging, but what you really need to do or know is how to use what you have. For example, on the HQ190 scope, there is a feature called near focus. Now, this feature is not programmed onto your scope and it's not on your stack. You need to actually program it on one of the buttons yourself, but it's an invaluable tool. So again, it's not about having the highest end equipment, but it's about knowing and being able to use what you do have. And then image enhancement, no matter what system you're using, I think all of the systems now have some form of image enhancement, whether it's Olympus with NBI, whether it's Fuji with BLI, whether it's Pentax with iScan. But image enhancement really does help to look at these lesions closer. Don't forget to look at the gastroesophageal junction. Lots of cancers arise at the gastroesophageal junction, and sometimes it's better appreciated in retroflexion to look at the back end of the gastroesophageal junction. When you're taking a closer look, what you really want to look for is a demarcated area. This is a concept that I've mentioned many times with regards to colonic polyps, gastric imaging, all sorts of imaging, and sometimes it confuses people. But what you do, or what the definition of a demarcated area is, simply one area that looks different to another. That's all it is. So pattern on the one side, and there's a different pattern on the other side. Once you find an area that looks different, you then want to ask yourself, that area that you're looking at, is it regular? So you're looking at two things. You're looking at the vascular pattern as well as the mucosal pattern. Remember, with NBI, you're actually looking at the vascular pattern, but it's interchangeable because the vascular pattern outlines the mucosal pattern. So you're looking at whether that area is regular. If the area is irregular, you're looking for one further thing. Is there still some maintained structure within that area, or is there absolutely no structure? Is it completely amorphous? So when you have a regular to regular area, it might just be a dysplastic area. When you have a regular to irregular area, but there's some maintained structure, that's usually going to be either high-grade dysplasia or an early adenocarcinoma or early cancer, which is amenable to endoscopic therapy. But once you have absolutely no maintained structure with amorphous area, that's when you're talking about deeply invasive submucosal cancer, which is most likely going to be uncurable. And what it looks like often in Barrett's is crowding. And I'll show you what that means. So the glands just look very bunched up, very small and crowded together. Remember, the terminology for looking at squamous is a little bit different. There we look at intrapapillary capillary loops, something I'm not going to touch on today. And then the utility of chromendoscopy, and I'm going to try and show you how that helps. So remember, when we're talking about Barrett's, you want to use acetic acid, and you want to use about 1.5 or 2% to 3%. There has been reports of acetic acid-induced colitis and that. So you ideally don't want to use 5% and 10%. I know a lot of centers do use vinegar, but the problem with vinegar is sometimes when you buy vinegar from the supermarket, it will just tell you on the bottle more than 5%. Is more than 5% 50%, or is more than 5% 5.1%? That's the big issue with it. So you can dilute down the vinegar, but ideally you want acetic acid 2 to 3%. And then just remember orientation, because that's important for not only you, not only your surgeon, which might need to take out the lesion, but also your pathologist. So you want to correctly orientate lesions. Now, orientation can be tricky. We talk about anal and oral, or proximal and distal, but we also talk about the clock face. Now, remember, the clock face is variable because you can easily bring 6 o'clock to 12 o'clock by rotating your scope. So you need a reference landmark. And the reference landmark should be entering your GOJ, going into the stomach, putting the lesser curvature at 3 o'clock and the greater curvature at 9 o'clock, and coming back in that orientation. So then you know lesser at 3, greater at 9. You come back with the straight scope. You use that orientation to describe the clock face of your lesion. So is it 1 to 5 o'clock? Is it 9 to 12? Whatever it may be. So this is just an example of a demarcated area, and you can beautifully see that there is a demarcated area here. It's a bit subtle. I'll show you this case in a video, but it's regular to regular. This pattern has been beautifully regular, but that's also regular. And this is what I mean by crowded glands. So this looks like that, just bunched up a lot tighter together. So that's probably an area of dysplasia. So that's your regular area, and that's your regular area as well. This is a little bit different. So here you're starting to lose some regularity in the lesion. So you can clearly see the demarcation, and it's well highlighted with, this is the combination of acetic acid and NBI. And you can clearly see the regular area, and then you can see the irregular area. But there is still some vascular structure within it. Yes, the glands are crowded, but there's areas where you lose glands. However, there still is some vascular structure. This is an example of an irregular area with no structure. So you can beautifully see the regular part. You can see the demarcation line perfectly, but in the demarcated area, there is absolutely no more structure here. You're not seeing glands, you're not seeing vessels, you're seeing complete loss of structure. So let's move on to the first case. I want to spend more time rather on the video than on the case presentation or anything else. So the first case is a 50-year-old male. He's a classic patient with metabolic syndrome, hypertensive, type 2 diabetic, dyslipidemic. He had a long-standing history of GERD since childhood. He's a non-smoker, and interestingly, has a strong family history of Barrett's and his adenocarcinoma. Both his mom and his sister had Barrett's, and his mom actually demised from an esophageal adenocarcinoma. So you can imagine quite an anxious patient as well. The patient had a scope by a previous endoscopist who noted a long segment of Barrett's with 2 concerning nodules, and they were biopsied and showed at least adenocarcinoma in situ. So remember, biopsies don't get deeper, and that's why your pathologist is going to say at least, because we're not sure what's happening deeper than that. Your biopsy hasn't gone deeper, so they can't tell you how far down it's going. The patient had a staging CT, which essentially just showed no local regional disease, or disease limited to the esophagus. So I'm going to take you now to the video of the case. Please do shout if you cannot see. So I'm going to skip the first part. I think the first part is an interesting discussion, but a completely different discussion altogether. And maybe if we have time, we can talk about it. But this patient had a massive inlet patch. This is just below his upper esophageal sphincter, and you can see quite a big inlet patch. Argument here is this just an inlet patch or is this actually related to his Barrett's? So I did assess the inlet patch in white light as well as in chromoendoscopy with a virtual chromoendoscopy with NBI. But you can see a very, very large inlet patch, which you'll see the end of it now. That's the end of it. And then you see the start of his Barrett's segment. So this patient had an ultra long Barrett's, more than 10 centimeters. His C and his M were almost the same. And again, the first thing to do is to ensure that your esophagus is clean. Now, just bear in mind that this patient was intubated because I was planning to do an endoscopic resection. And so I was not concerned about irrigating and using water. I was not worried about aspiration. And again, if your water pump is set too high, and if you're irrigating and blasting lesions with the high water pump, you're going to induce some degree of trauma and bleeding, and that makes it very difficult to assess. So don't forget to turn your water jet down when you're washing these lesions. And you can see that this lesion probably was spontaneously bleeding. So just in terms of your first impression or your blink impression, there's certainly concerning features. Spontaneous bleeding, extra redness, and definitely bulkiness with these two nodules here. So your first impression is already telling you there is a problem here. And I'm quite worried that the problem is that of malignancy. So then I took a closer look. Now, this scope didn't have near focus. It's just an H190 scope. So I want to show you that even with basic scopes, you can get decent imaging. So this is without near focus. And what you can see is that it's not so easy to appreciate, but this whole area essentially is demarcated. So if you look at my mouse, that's the regular area. And this whole area here is actually demarcated. And the area within the demarcated area is not regular. It's irregular, but there still is some structure. You're still seeing some blood vessels. You're not seeing that amorphous whirlwind total loss of vasculature. So I call this a demarcated area. I call it irregular with some maintained structure. Now, just be careful that you actually have to assess the whole nodule as well as the back end of the nodule, because just looking at one demarcated area doesn't mean there's another area that's completely irregular with loss of structure. And that would mean that there may be an area that's deeply invasive. So you have to assess the entire region. And again, there you can also see that there is a demarcated area here in the center. It's different from that area. It's irregular, but there still is a bit of structure in there. I'm just going to move a little bit forward there. I think there's a better view that I managed to get at some stage. So a lot of overlying fibrin on this lesion, a bit of mucus. And yes, once you traumatize a lesion and it starts bleeding, it is difficult to assess it in NBI because remember, NBI enhances everything that's red and the fluid in the blood tends to be very annoying. So there you beautifully see it, okay? So that's a demarcated area and there's no regular pattern. You don't see a regular gyre type pattern. It's irregular, but there still is some structure. There still is some blood vessels on this area. So I thought this to be an early adenocarcinoma within the Barrett segment. Now, the one thing I want to highlight is when you find pathology, whether it's in the colon or whether it's in the upper GI, our first instinct is to switch off because we find the fungating tumor in the cecum and we say, fantastic, we found the cause of iron deficiency. We biopsy it, we switch off and we come out. But then we miss the synchronous cancer or we miss the dysplastic polyp on the other side that also needs to come out. And when you find one lesion, that's a harbinger that there's going to be others. In this patient, you know that there is a malignancy. You know that his biology is bad. You know that his genetics is bad. And the fact that you found a cancer is showing that the other areas of Barrett's is at risk of dysplasia. So you should not switch off when you find something malignant or something concerning, but you need to switch on. And hopefully I'm going to show you that with some more subtle findings in this patient. So I went down. Remember, you do want to just examine sequentially. So I like to start from distal or from anal and go proximally. So I was looking in NBI and I was just looking with my blink impression. This video is edited, so I do skip ahead at some stages. And then I'm withdrawing my scope and going a little bit more proximally. Again, freeze. Freeze, take time, appreciate what you're looking at. Looking at a moving image with blurriness is very, very, very difficult. So then if you pull that scope a little bit back, there's something else going on here. And here's where your blink impression tells you again. So there's two obvious nodules, which are cancer. But there's something more subtle happening there. Okay. You get the impression that there might just be a little bit more bulkiness there. So what you want to then do is take a closer look again. And if you look there closer, I've put it under water and I've done NBI, virtual chromoendoscopy, and then you're seeing something else. Now you can appreciate under virtual chromoendoscopy the bulkiness a little bit better. So now it's standing out and staring at you a little bit more. So you can appreciate that that's a little bit bulky, but you can also appreciate that that's a regular mucosal vascular pattern, and here's a demarcation. So there's another demarcated area here. And if you look at this demarcated area, areas do still look regular. So it is regular to regular. You could argue that there are some areas of irregularity with still some maintained structure. So I felt this to be a focus of high-grade dysplasia. And it is very important to identify this because remember in Barrett's, you do not want to burn RFA. You do not want RFA visible dysplasia. You always want to resect visible dysplasia. The problem is that bulkiness. When you do RFA, you're not doing full depth treatment. You're just burning the tip. And that is just the tip of the iceberg. So what you will end up doing is you will end up creating neosquamous vascularization, neosquamous epithelialization. So the squamous tissue is going to grow over it, but the bottom of the iceberg is still there. So now you're going to have squamous growing over your dysplastic adeno area. And that's a recipe for disaster. That's Barrett's, and that's a big issue. So here I'm applying acetic acid. Again, the patient was intubated, so I wasn't too stressed about aspiration. Just be careful that all of these Barrett's patients, by definition, are going to be metabolic syndrome. They're likely going to have obstructive sleep apnea, and they're not going to tolerate unsedated gastroscopies, and a lot of them will require intubation. So remember, when you're doing acetic acid, what you're looking for is early loss of acetowhitening. So you do actually have to wait a couple of seconds to appreciate early loss of acetowhitening. But I think here you can already see that those nodules are starting to lose a bit of the whiteness. So the white stained mucosa is normal. You're looking for the areas that don't take up the white or lose the white very quickly. And those nodules you can see are a little bit pinker. They're not as white as the rest of the Barrett's. And this is something that I love doing. It's not so much in the guidelines, but I think there's really good value in combining acetic acid with NBI. And look at the images that you get when you're doing that. You beautifully see mucosal patterns and vascular patterns when you're doing that. So I'm going to skip a little bit forward here for the interest of time. So I'm just fast forwarding there. And I want to just show you how this makes the demarcated area jump out a lot more. So now look at that. Now you beautifully see the area of demarcation. You can see your classic normal mucosal and vascular pattern. And there you see your demarcated area with the crowding of the glands. So I thought that this was an area of high-grade dysplasia. And again, this is very important to include in your resection, not just take the malignant areas. So what I proceeded to do was a ESD for this patient. I went very wide. These are my markings. So this is where I cut along when I was performing the ESD. So I went nice and wide to include those nodules and to include that area of what I believed was high-grade dysplasia orally or proximally or whatever you want to call it above those nodules. So you can see my markings nice and wide around the nodules, including any areas of visible high-grade dysplasia, which I picked up or felt I picked up endoscopically. And that was the end result. So that's after the resection. And you can see that I probably did about 65% resection of the circumference. And I went quite big. So it's a very large area from the GOJ, quite high up. And I ended up taking out quite a big segment of this patient's esophagus. And I didn't feel that a CAP EMR was going to cut it. I thought ESD was the only way to get everything out unblocked. So I went with an ESD, not in CAP EMR. Again, technique and method choice of resection, I think, is beyond the scope of this talk. The scope talk is more about imaging. So we can chat about that at some other stage. But I decided to perform a ESD, and I'm just going to quickly show you the resection specimen, but I know Prof Hale is going to show you that in a bit more detail. So let me just jump forward. That's essentially what came out. You can see your malignant nodules there, and you can't see too well, but that's the area I was concerned about as being dysplastic. Thanks, Prof. I think I'll hand over to you now.
Right, thanks, Vikash. And I would just like to echo your opening statements from the point of view of communication, because I think that the success of these wonderful procedures that you're doing uh, really comes about because of the communication that happens between the histopathologist and the endoscopist. Um, and I would echo your thoughts about the art as well, and also the time, because these sort of things need time to be spent on them, and it takes you need to make that time available. And it takes me, certainly from the time I get the case, looking at it and that sort of thing, it takes a few hours really to actually sort these cases out. And it starts right from the visual examination of the resected specimen. And you know, as I do, that I often phone you before I even start and say, Vikash, would you like to come down and have a look at it? Because one of the very important things that very few people recognize, if they haven't spent any time in pathology, is that what you see at the time of operation is completely different when we look at it once it's fixed and bottled up in formalin. Vikash, I can remember the first case that you
I
and I
remember that
looked at.
very
You
well,
remember?
Prof.
We looked at that, and Vikash was talking about X, Y, and Z. I thought, well, I don't know what X, Y, and Z is because I can't see it. And one gets through those sort of things. And it's very, very important to that communication is absolutely essential. And I could tell you there is nothing worse. If I, as the histopathologist, excuse me, don't fully understand the resected specimen, I put it aside, I phone Vikash and say, let's talk about it, come down if necessary, and we go through it. And it's very important. I mean, those visuals that you showed us, I think, are really stunning. And so let's go through. So I'm going to just give a little bit of a talk on how we approach it, and then very similarly as Vikash has done, show you the real life example of the patient that he's just discussed. So all right. So I've taken a couple of diagrams. Can everybody see that picture, by the way?
Yes, we can,
Okay.
Prof.
Great, thanks, Cheryl. So this is actually, I've just taken a couple of schematic diagrams from the Royal College of Pathologists of Australia, who did a pro forma some 10 years ago now as to how to handle these endoscopic submucosal resections. And essentially what they do is they do exactly what we do. And what we do is that we take the resected specimen, as Vikash showed you, and very, very important, as Vikash shows you, to pin it out onto a board. Now, by tradition, I've always used cork, and I introduced Vikash to cork. It's readily available, and but you can use things such as polystyrene and so on. Doesn't really matter. It's obviously got to be resistant to formalin. But what is very important is the material that you pin it onto must remain rigid. Because when this tissue gets into formalin, it curls up at the edges. And when things curl up at the edges, it makes the processing and the dissection of that specimen almost impossible, particularly if it's thin and particularly if it's small. And in fact, you effectively really undo all the good that has been done during the operative procedure. So that's it must always be pinned out. Right, so this is a bit different. So this is the way the Australians do it. So you see there, I don't know if you can see it on the bottom of the screen, but this is clearly delineated as oral or proximal, and this is delineated down here as distal or anal. Now, what the Australians do, and I'm not sure if they do this all the time, but they take sections in a transverse manner. And I don't think it really matters. I don't particularly do sections in a transverse manner, because to me it's counterintuitive. I'd rather do things in the direction of flow, and so I can actually understand it. Because I think when one is looking at this, I personally like to think of it, I visualize this portion of tissue in the patient. So I almost visualize myself as going down, as being part of the endoscopy and seeing where it is. And I think that's very important, because then you can actually interact with the endoscopist, and also importantly, you are able to interpret the resection. So these holes represent the pins that you saw in the previous case, and notice the dimensions. So we call this bread slicing or bread loafing, and the whole biopsy is put through. Now let's just put this into perspective. So this is a piece of tissue that is some 4 centimeters by, say, 3 centimeters. Now, when we take our blocks, the blocks that we take are about 2 millimeters thick. So we will take a 2 millimeter slice. And when we cut those sections, when the technologist cuts those sections, that is a 4 micron slice, okay? So every block that is sectioned, so if we've got here, for example, 1, 2, 3, 4, 5, 6, 7, 8, call it 10, 11, or 12 sections. So we are examining histologically, let's make it 10 sections. 10 sections, each of which will get a 4 micron slice. So effectively, excuse me, all we're looking at is 40 microns of tissue over a 4 centimeter piece of tissue. So what we're sampling, in fact, is very small. Now, you may say, well, that's a bit of a disaster. Well, the answer is not really. Because if we see an area that requires further investigation, we can then go and delineate that particular area. So what I do is, so let's just now just have a look at the anatomy. So here you've got the mucosa. So this is not squamous mucosa, it's gastric mucosa, but you've got the mucosa, you've got the submucosa, and sorry, not the submucosa, the lamina propria, you've got the muscularis mucosae, and then you've got the submucosa. All right, so that's just the anatomy. So mucosa, lamina propria extending down to the muscularis mucosae, and then the submucosa. Now, bearing in mind that it's very important to pick up these structures, because that is what delineates the staging of the tumors if this patient has a particular tumor. So here it is. So this is the, if one looks, for example, at the AJCC staging, which is similar to the TNM stage, here in South Africa, we use the AJCC. It's fairly well internationally recognized and used. And in fact, all the medical aids, for example, use the AJCC staging, and all the histopathologists are well used to that for all the tumors that we deal with. I wouldn't worry too much about M1, M2, and M3. We decide whether it's a tumor in situ or if it's a T1A lesion. If it's a T1A lesion, then it is confined or is kept, it's within the muscularis mucosae. In other words, it hasn't breached the muscularis mucosae. It may go into the muscularis mucosae, but it hasn't breached it.
Hi, so that one stool came back.
If it breaches the muscularis mucosae, then it becomes a T1B lesion, as you see here. Now, what is also important, and as Vikash outlined, is that the prognosis. So if we take the T1B lesions, the evidence suggests that if there is invasion to the inner third of the submucosa, the middle third, or the outer third of the submucosa, so you can't see the muscularis propria here, at least I can't see it. I'm not sure if it's on the diagram. I've got a bar underneath it. But the evidence suggests that if the invasion is present in the inner third, middle third, or outer third, then that affects the prognosis. So that's SM1, SM2, SM3. So basically, it's quite simple: inner third, middle third, and outer third. And effectively what it's doing is deciding or delineating for you the bulk of the tumor. Because as we know, basically the size of a tumor is what determines the prognosis. Right, so this is the patient that Vikash has just shown you. And you can see that's the picture that he sent to me. And what that shows is the tumor. I haven't shown you what it looks like under formalin. No. Okay, so I've taken a picture as well myself under formalin, but I thought I would use this picture. So what is delineated very nicely is the areas that he thinks is malignant. So he's taken a photograph, sent this through, and you can see here he's annotated it as anal and oral, and he's concerned about this focus here, and he thinks this is tumor. Now, I've delineated this as red there. And the reason why I've delineated that as red is that we use 2 inks. And the reason we use 2 inks is to work out where we are in this tumor. So the ends of the resection, be it the anal or the oral end, I cover the mucosal surface with red ink. Okay, the mucosal surface, both ends. And then the circumferential or the deep margin, if you like, which you can't see here because it's still pinned, but I will show you on the screen, I color that with black ink. So when I look at it, I'm able to determine exactly where I am. So this now, and please excuse the artwork, and I have inverted it. So that's the anal end and that's the oral end. And as I said to Vikash, we have to sort of standardize on which way we're going to put these things up so that when we take pictures, we can make sure that there is a uniformity. So this is the oral end. I hope you can read my writing. And this is the distal end here. So if you look at this here, so the anal end, these 2 nodules, you see that? And if we go back to that, those are those 2 nodules there. So notice, and if I go through it, through my scroll, I've got here the measurement, which is 75 millimeters. That's 75 from there to there, and then the width is 40 millimeters. Because Vikash also will have measured his size of his resection. Notice Vikash mentioned, for example, pick up where 3 o'clock is, and I do the same. So I say that is 3 o'clock. And that, by inference, is 9 o'clock. Now, the next thing is that because this is 75 millimeters in length, it is too big to go into one cassette. So I have to divide it. And that's why, when you see there, I've got red ink and red ink there. And I showed you that on the previous diagram. So when I come to assess it, so I now breadloaf it in a longitudinal manner. And you'll see that I've put a line across there, and that represents the area of division, which I've arbitrarily, or not arbitrarily decided, where I divide this piece of tissue. So I don't put it into a Swiss roll because I don't want to disturb any of the anatomy. You see that I've measured the size of the tumors, these nodules, 13 by 14, and then 12 by 12, okay? Notice that I've said that this one is ulcerated and hemorrhagic. So I know exactly where I am when I read the sections. And here, I put here A1 and A2, and that refers to my blocks. And then on the other side, because I've breadloafed it, and I've taken my sections from left to right, and on the other end, I've got A21 and A22. Now, when I look at it, this is what it looks like. So I never look at the sections, and if we look here, I've got A1 and A2. And I've laid these out purposely like this because I'll start off at A1. So now I'm visualizing, I know what I've put through, and I'm visualizing that this is the first block there, that's the second block there. So I'm basically going from one end to the other end, okay? And I repeat that exercise. Now, and you need to do this. So I've got a whole lot of slides from A1 all the way through to A22. You can't see the others. And I now am forming in my mind a microscopic representation of what I can picture in my mind from a macroscopic point of view and what Vikash has seen. So now let's go through and have a look at it. Okay, so now I'm going to take A1 and A2. So A1, so let's see where A1 is. So A1 is here. It's the first block. And here you can see that there is, sorry, I'm going to have to share again, I think. Yeah, I'm going to have to stop the share. Share that, stop share. Share again. Oh dear, have I lost the picture? Where's that? Sorry, there's a bit of a technical glitch here. Minimize that. What's that? Right, so go back to this. A bit like flying a 747, this. Right, okay. So there we are. So this now is A1. And if we go back to the, well, I'm not going to go back for interest of time. So what I've got here is I could tell you exactly where I am. So now on the mucosal surface, I said there was red ink. And there is the red ink. So that is that resection margin at that end. That's the red ink there. And then this is the black ink, which tells me the deep resection margin there. So I know exactly where I am. I could go through this and say to Vikash, okay, in section X, Y, and Z, this is where we are. Now, Vikash was concerned about dysplasia. So I could tell you that there was dysplasia or malignancy all the way through to section to block 15. In fact, all the way through to block 20. So most of that in the proximal area or the anal end, if I remember correctly, most of that, in fact, was dysplastic. So let's just have a look at it. So this, for example, is block A20. And there is the dysplasia. Okay, there's the dysplasia. And Vikash was talking about RFA. You can see why the RFA doesn't work, because that's quite deep. There's the muscularis mucosae. There, okay. And you're starting to get a bit of an abnormal architecture to these crypts. You've got extensive intestinal metaplasia in some of these crypts as well. So there's the intestinal metaplasia and the goblet cells. And then if I go to another area, this is A8. So this is now on the other side. And once again, showing you the dysplasia. And you can see under this fold, it was starting to get cribriform architecture, this sort of thing here. Okay, this is all starting to fall into the category of high-grade dysplasia. Look at these huge nuclei. Okay, a cribriform architecture which is starting to develop. So that's certainly not low-grade dysplasia. And then notice the ink. So there's the red ink, so I know where it is. So it's close to the resection. But importantly, the actual resection margin itself. And Vikash is always very, what's the word, strict on saying is the actual margin involved. So here's the margin with the black ink. That's the deep margin, and the actual margin itself. These are dysplastic glands, but the margin itself is okay. So it's clear. And then last but not least, just to show you the tumor. And there was quite extensive tumor present in those nodules. And this is the tumor there. You can see, I can't go any lower, unfortunately, but that's the tumor, the infiltrating adenocarcinoma. And here, you can see the muscularis there, muscularis mucosae, which is there. And the tumor is certainly abutting on the muscularis. And if you look here, so that's a good area there. So there you can see tumor there, and there's the muscularis. Okay, so this is a T1A lesion and was resected. Okay, Vikash, over to you for the last case. I'm not sure if there are any questions. We take them at the end, probably.
Thanks, Prof. I'm just going to squish this one quite quickly because we don't have a lot of time. So I'm just going to go very quickly through the case presentation and also not spend too much time on the video as well. So essentially a 74-year-old male, previous kidney transplant. He's on immune suppression, which is probably driving his risk factors for all of these malignancies. Metabolic syndrome, strong smoking history, previously had Hep C, treated with SVR, and was known with a long-standing history of Barrett's esophagus. Previously had biopsies done which showed high-grade dysplasia. Had no resections, but previously had RFA. He's been obviously on a surveillance program. They're small scattered islands of Barrett's with no real C or M Barrett's, just a few random islands. And random biopsy of one of these islands came back as high-grade dysplasia / intramucosal adenocarcinoma. I'm going to show you the video, and perhaps Prof can also comment when we get back to him about the difference between high-grade dysplasia and intramucosal adenocarcinoma. Can we tell the difference, and is it, because it often confuses endoscopists and gastroenterologists. Is it the same thing? Can we actually tell the difference? But let me just squeeze through the video quickly. So just to take a overall impression, like I said, a blink impression, and you can see that that's the GOJ in the distance. And you can see that there is squamous pretty much everywhere. There isn't much Barrett's tongues. But what you do see with your blink impression is, again, an area of perhaps a bit of extra redness, but certainly bulkiness. And again, bulkiness, nodularity in Barrett's, always concerning. So again, just from your blink impression, you're thinking that's probably where the issue is, where the adenocarcinoma is sitting. So I then proceeded to do a closer look with image enhancement. And here I did have near focus. So I actually put it underwater. And what you can see when I put it underwater is it actually floats that lesion up and makes that bulkiness more apparent. So now you can see that little donut staring out at you a little bit more. Within that area, you're seeing an area here which clearly is irregular. So you can see an irregular area. There is no nice mucosal and vascular pattern, but there still is some vessels. So I call this an irregular area with some maintained structure. So I thought it was an early adenocarcinoma. And certainly, I think this is just the tip of the iceberg, and the whole bulky area represents actually adenocarcinoma. So I proceeded to examine what I could. Now, this is very difficult because now you have neosquamous epithelialization, and you can't really assess the pattern of the rest of the esophagus. So this becomes a bit of a guessing game. So I assessed what I could. And these are some islands I'll show you now opposite that nodule. So this is not where the nodule is. But in these islands, you see a beautifully regular mucosal and vascular pattern. So these little islands I wasn't too worried about as being dysplastic or malignant. But we can't see what's under the rest of the squamous. So there could certainly be other foci of high-grade dysplasia or of cancer. And that's where the issue comes in. And that's why you really got to get it right the first time and resect high-grade dysplasia that's visible, not just burn it, because this situation becomes very difficult to treat, especially in a 74-year-old male with a lot of comorbidities who might not tolerate an esophagectomy well and is not going to be a great candidate for surgery. But again, within that nodular area, so I sat on the nodular area with my cap, I put it under water, I'm using near focus. This was an HQ190 scope, so I had near focus. And you can see that there's several areas. And again, that looks irregular, but some structure. And several areas where there's just an irregular mucosal and vascular pattern, but difficult to appreciate because it's overlain by squamous epithelium. So again, I proceeded, I didn't go with the cap EMR because I felt the RFA was going to make this lesion fibrotic and it wouldn't come up in the cap. And I was worried that I wouldn't get a good margin on it. So this was a bit tricky. I proceeded to marking it with the EST knife and then performing an EST. But this was a bit tricky because how wide do you cut? You can't assess the vascular pattern. You can't assess the mucosal pattern. So I really had to just use and go nice and wide around that nodular or bulky area. And I really only had that to guide me. So this was a very difficult case. But why I chose this case is to highlight again that the importance of finding dysplasia within Barrett's and resecting it and not just RFAing it. And I think this is a follow on a previous case. So had we just cut out those malignant areas and left that dysplastic area on top and RFA'd it, this is the potential it had of becoming. So this is what you want to avoid because this is a very difficult situation to deal with. Essentially, I'd marked out the lesion. I went what I thought was as wide as I needed to go, and I proceeded to another endoscopic submucosal dissection. I can hand over again to you, Prof.
Yeah, thanks, Vikash. So let's answer that question. I don't really know what the answer is. The reason why is, so I was just looking, for example, if you look at the AJCC classification, stage TIS is in situ. So if I show you, for example, let's go back to this case. So I've just picked up this area here. And we could spend hours poring over these things, deciding whether they are invasive or not. And it's almost like saying, ask 10 different pathologists to get 10 different answers. So here, for example, I think it is fairly straightforward to say that by virtue of its mass effect, is an infiltrating tumor. And you can see that it appears relatively regular, but it is also irregular. So if you look, for example, this area here, you see typical cribriform appearance. Now, some people may say, well, that's just a bulky adenocarcinoma in situ. And you'd be hard pressed to disagree with that approach. But then when you search and you do levels, and that's where these levels that I was talking about come into play, because then you start to look for what you call infiltration. And this is the sort of thing that we look for. So for example, if we look at this crypt here, you can see that there is blurring of the interface between the epithelium and the lamina propria. So that would be early infiltration by the lamina propria, of the tumor by malignant cells. If you look at this gland here, this is starting to look a bit irregular. You're starting to see blurring there. And the problem for Cash, as you said, is like this art. And, histopathologists will look at something and say, gee, did I call this malignant? Okay. And the last thing any histopathologist wants to hear is a colleague come up and say, I've reviewed this case, would you have a look at it? You reported this, you think, oh, gee, what have I missed? What have I overdiagnosed? And it is frightening, in fact, to think that we call it inter-observer, but it's intra-observer variability. And if you look there, for example, I think this is an area of infiltration. Effectively, if it was still within the lamina propria, then we would call it a TIS. but this is outside the lamina propria, abutting onto the muscularis. So therefore it's a T1AB. Sorry, a T1A lesion. So Vikash, difficult answer. I'm not sure that that I may have answered it properly. But yeah, it is a problem. Let's move now to the second patient. So the second patient, I'll stop the share and I'll show you. So that was the resection. And what I want to show you quickly is the one block, and really just to emphasize what Vikash was saying, how this is, I mean, this is real a sheep in wolf's clothing, if you like, or a wolf in sheep's clothing. Maybe that's the right way to call it. But look at this. So there is the squamous mucosa. And look at this extensive infiltration beneath the mucosa by infiltrating adenocarcinoma. And even down here, there's this island of infiltrating adenocarcinoma. Now, all Vikash would have seen was squamous epithelium on the surface. And if he was lucky, he may have picked up this irregularity in the mucosal surface. But that's all he would have seen. Hence the need to make sure that you go through. As he said, don't say, yes, there's the money, and move on. The 1 minute rule per centimeter, very good answer. So there it is. There's the infiltrating adenocarcinoma, which is undermining the Barrett's. And here you can see the tumor actually infiltrating between the fibers of the muscularis mucosae. So this remains a T1A. It's only just a T1A. There's a tumor island there, but there are slips of muscle just there. But you can see how close it is. And there again, you can see tumor there, and then these slips of muscle is just infiltrating. I mean, this is just a T1A. Okay. Okay, Vikash, over to you.
Thanks, Prof. Yeah, I think that actually is we've reached our time limit, but I think it was amazing. And I've learned a lot from our interactions, and it took us a while, I think you can agree on this, to actually get it right. To actually get the orientation right, pin the specimens right. And it really took us coming together. Like you're saying, you'd invite me to the lab. And I remember you pulling out that first specimen from the formalin. And I looked at it and I was thinking to myself, that doesn't look like what I resected. I didn't take that out. Because the formalin really just does distort that thing, and to an incredible degree. And I didn't appreciate that. And I certainly appreciated it as soon as you pull that thing out of the little tub, and I appreciated what it does. So again, that highlights the importance of communication. And these cases are difficult. These cases require a bit of finesse. They require fine tuning. A millimeter can mean the difference between an R0 and an R1 resection, between endoscopic cure and, the patient needing further therapy like an esophagectomy. So you really do have to fine tune it. And, Prof Hale inviting me to his lab and looking at his specimens and looking at under the microscope, and just his presentation now just really helps us as endoscopists to assist our pathologist to get the best outcome that we can. And we really do need to come together. He showed you beautifully how you braid slice and how he processes his images. And that gives us a better appreciation and understanding of what you do. And it helps us to assist you. So yeah, thank you for, it really is an MDT, and it really is very, very important. So thank you for that. And thank you for inviting me to your lab and looking at these things. And I've just certainly learned so much more. It's given me a lot more perspective and how to deal with these cases. So I think the message is clear that endoscopy
Have you
and
addressed that
pathology are both
question,
hard work.
Vikash?
in the chat.
One question from the chat, Prof.
Is there a question for me?
No, there was a question
is that
about
a lymphocytic infiltrate?
Yeah.
Well, yeah, I'm not sure in which.
I think it was the first one, Prof.
Probably yes. Yeah, but I wouldn't have been concerned. It would have been a reaction to the tumor. You may see it. They could be ulcerated. You can get mixed inflammatory infiltration, granulation tissue, and all that sort of thing. And that also can be confusing, particularly if you've got ulceration.
So Vikesh, I mean, terrifying to show us these lesions that can be so easily missed. And I think with colonoscopy, we've got some very nice standardization on how to approach, your withdrawal times and what to look for. As far as upper endoscopy is concerned, 1 minute per half centimeter or whatever in the esophagus. What about the stomach? Is there a minimal kind of surveillance time or screening time that you should be using?
Yeah, so I mean, they talk about 7 minutes, but if you know that the patient has atrophic gastritis, 7 minutes certainly doesn't apply. Then I would also look very carefully and examine, probably a minute per centimeter. So they talk about 7 minutes, but that's a standard gastroscopy. That's not a patient who has atrophic gastritis. I must say, and I do have my own bias in that a lot of the time the patients do have a history of something bad when they're coming to me. So I do spend a lot more time knowing that they have something more. But like you said, Prof, I think the
Yeah,
upper
I mean, that is a very
you.
important point because, most of us have busy endoscopy lists and we're screening patients. And, it's a very different scenario to someone like you who's getting the pathology. But then again, we can't afford to miss these lesions. So we've got to find that kind of, optimization or balance between keeping a list going but picking up lesions. And I think the only way you can do it is by being systematic.
Absolutely agree, Prof. Systematic is the way to go. And again, I'm going to emphasize knowing your equipment. I think we all have decent equipment and the tools to do it, but not many are familiar with where the freeze button is on your scope, where the near focus button is, the use of image enhancement. So it's not about getting the latest generation scope. It's about knowing what you have and knowing how to use it the best that you can. And I'd argue that most of us do have scopes that can do decent quality imaging, high quality imaging, but it's difficult. The stomach, especially, very difficult to assess. And even the experts get it wrong a lot of the time. So not an easy situation and definitely difficult. But again, I want to emphasize when you find something, switch on and look more carefully at the rest. Don't switch off and think, I found the money, like Prof said, let me stop there. That's when you need to actually just start looking a little bit more carefully.
Excellent. Let's wrap up.
Okay. So just in closing, I think this was a great start to our intended, vision for these sessions. Yes, we just focused on Barrett's and esophagus, but you can see how much there is to talk about, and we could probably have done 4 sessions just on Barrett's. But we'll hopefully progress this to other areas, gastric, duodenal, colonic, and I think this is a very valuable meeting. And we've actually had this chat about correlating endoscopy and histology and coming together and actually developing a bit of an encyclopedia or something of that sort, but very important topic. So again, thanks, Prof, for your time. And as much as we need to develop expert and interventional endoscopists, we also need to develop expert GI pathologists. And the one goes with the other. Like you said, 10 different opinions from 10 different people. So having an expert endoscopist doesn't help if you don't have an expert GI pathologist to interpret what you're looking at as well. So we've got a long way to go. We certainly, I mean, all guidelines say 2 expert GI pathologists looking at the case. And finding just 2 expert GI pathologists in your area is you're probably not going to find that depending on where you are. So we've got a long way to go. So thank you, Prof, for your time and for those beautiful pictures that you showed us. Thanks again to echo, the University of New Mexico and echo team in India. Again, the recordings are available on the Gastro Foundation website. Thank you to Prof Casanidis and the Gastro Foundation and to our sponsors as well. And I think next week we resume with an IBD session.
Thanks,
Professor.
Excellent session. And can we have more of these? Huh? This really is unique, this session today. Excellent, Martin. Thank you so much.
Thank you. Pleasure. That's enjoyable. Thanks, guys.
Thanks.
Well done.